Zoll technology will guide you to meet the 2015 CPR guidelines. High-quality resuscitation on the move is achievable, and high-perfusion CPR is within reach. When it comes to helping you deliver high-quality CPR, no one offers you more than Zoll.
Thank you, Mr. Chairman, for your kind introduction. Ladies and gentlemen, this is about chest compression, depth and rate. It looks very simple, and it might be simple, but at the same time it's the most essential part of CPR, and I think you will not disagree with me on that. Some of my potential conflicts of interests related to this talk, I will be briefly talking about measuring compression depth, and I have received research grants from companies who do sell devices that can measure compression depth. And I have a number of intellectual conflicts of interest. I'm one of the editors of the ERC Guidelines 2015 and the Secretary of ILCOR, and I will be talking about ILCOR a lot. To start with, this is the publication of the Adult Basic Life Support and Automated External Defibrillation Recommendations of ILCOR, published 15 October last year. They can be found on ilcor.org or on cprguidelines.eu. Okay, this is the treatment recommendation, and as Peter Morley just highlighted, this is the way we synthesize the result of the evidence reviews of ILCOR. And ILCOR recommends a compression depth of approximately 5 centimeters, while avoiding excessive chest compression depths greater than 6 centimeters in an average adult. And that is a weak recommendation based on low-quality evidence, and the approximately 5 centimeters is a strong recommendation, but also based on low-quality evidence, which seems contradictory, but really there isn't that much randomized trials around. In fact, there are none about compression depth and outcome. So it is low-quality evidence, but it is still a strong recommendation. And a lot of our discussions turn around this evidence, which is thousands of patients, American study, recent 2014 of Ian Steele, and it actually, the title is, What is the optimal compression depth during out-of-hospital cardiac arrest resuscitation of adult patients? And that is exactly the question that we, of course, want to be answered. And this is the most important, I would say, illustration of this paper, and it indicates the sweet spot. And the sweet spot is this area. I'm going to show it, yeah. This is compression depth in thousands of patients, mean compression depth, and this is probability, a measure of probability of survival to hospital discharge. And as you can see, around 4.6 centimeters, there is the highest probability of survival to hospital discharge. For lower compression depths, on the left-hand side, the survival probability decreases, and with higher compression depths, say over 4.6 centimeters, there's leveling, say, of survival. So survival doesn't appear to increase much with deeper compression depths. So that's a very important piece of information. It is around 4.6 centimeters in this largest observational low-quality evidence there for study. Now, of course, there might be also an upper limit where it is safe to compress the chest. And this is the single study, really, that is that recommendation of the upper limit of compression depth in the average adult is based on. And it is published it was published in Resuscitation 2 years ago. And this is really before and after the change of guidelines in 2010. You know, in 2010, the recommendation was 4 to 5 centimeters, and after 2010, at least in Europe where the study was done, it was at least 5 centimeters. This is the years, and this is mean compression depth, and the dark bars are no injury, and the white bars are injury in patients measured by, for instance, chest and other X-rays and CT scans. And as you can see here, the injured patients after CPR, the number of injuries increased for depths in 2011, which were the deeper compression depths following recommendations. So this is an indication that there is some more injuries for compression depths over 6 centimeters in adult patients. Now, I must add that these are not lethal injuries, but at least it is an indication. So, this is a values and preferences statement. And as we've heard in the previous presentation, this is really some additional explanation why we have chosen to formulate the recommendation as we did. And the first thing to notice is that by saying at least approximately 5 centimeters and not more than 6, we are consistent with previous recommendation. And that is quite important, because if you change recommendations, there's a lot of things that need to be changed. Devices need to be changed to measure compression depth or to deliver compression depth in mechanical devices, or training needs to be adapted. So that is a true concern. And secondly, we indicated that this was really based on the sweet spot in the study we discussed of 4.6 centimeters. So therefore, we said approximately 5 centimeters. Now, this was the recommendation from ILCOR. Now, how has this been translated into the guidelines of regional councils? And these are just 2 examples. One is the European Resuscitation Council. And the European Resuscitation Council said, well, our recommendation, our guideline is chest compressions should be at least 5 centimeters, but no more than 6. So we didn't select approximately as ILCOR formulated, synthesizing the evidence. We said at least, because at least was consistent with what we recommended 5 years ago. So we thought it was not worth it, so to speak, to say approximately. We stuck with at least, and also no more than 6 centimeters, which was also what we recommended 5 years ago. And the American Heart Association actually did the same, decided the same. They say at least 2 inches or 5 centimeters for an average adult, while avoiding excessive chest compression depths, which is, according to ILCOR, greater than 6 centimeters. Okay, now that was compression depth. Now for compression rate, which is equally important. First, an observation on the left hand here, and this observation is in thousands of chest compressions, measuring every compression depth and rate. And interestingly, as you can see, this is chest compression rate per minute. This is depth in centimeters, and it was according to previous guidelines, 4 to 5 centimeters practice. As you can see, with increasing chest compression rate, depth goes down. And the cutoff point here is 140 per minute. So above 140 per minute, there is a significant decrease in chest compression depth. And that is not so much because of fatigue, but because when you're going faster, and I'm sure you'll recognize this, there is a tendency to become shallow. So it requires a certain slower rate to deliver every compression at its required depth. And otherwise, you become shallow. So you increase the rate, but you circulate less blood. So the net gain might not be positive. And that translates in survival. And again, published by Idris, this is average compression rate. And this is, again, a curve indicating probability of survival to discharge. And this is 100 per minute, this is 125, and the sweet spot, say, here is around 100, 125. So above 125, the survival probability decreases. So again, an indication that there is an upper level, which is around 120. And therefore, ILCO recommended to perform compressions at a rate of 100 to 120 per minute. That is a strong recommendation, again, but based on very low quality of evidence, because it was observational studies and there was some downgrading of the evidence, so ending up with very low quality evidence indeed. Values and preferences. The upper limit should be no more than 120, as we said. And that is, again, compatible with previous guidelines. So we therefore minimize, with this recommendation, we minimize additional training and equipment cost, which is also very important. All right, so we've discussed compression depth. We've discussed the importance of controlling compression rate. But how do we know how deep and how fast we are going with CPR? And this is just a summary of some of the devices that you might wish to use to measure compression depth and rate. And as you probably know, they're based on usually on accelerometer technology, which is a microchip measuring acceleration and therefore also depth and rate. Some have pressure sensors to also measure complete release, and some work with some, say, magnetic induction fields, but they all measure compression depth and rate. Now, just to appreciate what the current practice is, can I maybe ask for a raise of hands who is using these devices in their current, your current daily practice? Can I have a raise of hands? That is not very much. I think that is about 5 out of hundreds of people. So they're not quite popular. Now, Professor Judith Finn will go into much more detail about the value of these devices, but I have asked her to be allowed to just show one slide because it is related to my talk as well. This is the biggest study assessing the value of these devices, of measuring compression depth and rate, and the value on survival. It is a prospective cluster randomized trial, and the bottom line is that they didn't increase survival, which is quite depressing, isn't it? But I'm sure that Professor Finn will go into much more detail. The recommendation ILCO made is that they can be used not in isolation, but as part of a larger system of quality control. But more about this later on in this session. Now, how about mechanical CPR? Because if manual CPR is difficult because we need to measure how deep we are going, we need devices, why then not use a mechanical device to deliver exactly the compression depth the device is intended to deliver? And these are just a few, just to give you an overview, and there are more, and I've seen more in the exhibition outside. And again, I know that there is an expert speaker, much more expert than I will ever be on this topic, which is Professor Gavin Perkins. You know him. This is him with the adrenaline trial. But he's also an expert on mechanical compression. And I'm not going into much more detail, except that there is some role in CPR, but not in every routine use, every routine practice of CPR. But more about this in Gavin Perkins' talk later on. Now, we've discussed about standard practice, recommendations of ILCO, guidelines of regional councils, the use of mechanical compression devices, maybe also measuring compression depth. But can we improve compressions beyond current practice? Can we? And President Obama said, yes, we can. Related to CPR, I'll show you in a minute. because he spoke on the Precision Medicine Initiative. This is taken from the White House website on the 30th of January last year. And President Obama, and I'm quoting, said, "Most medical treatments have been designed for the average patient." Ha-ha. Didn't the ILCOR statement say the average patient? And as a result of this, the one-size-fits-all approach, that is the approach we are adapting. Treatments can be very successful for some patients, but not for others. And he called this precision medicine. Now, to be honest, he wasn't referring to CPR. I wish he had. He was referring more to genetics. But anyway, there are significant differences between individuals. There is no such thing as an average patient, although we use that all the time. And this is, for instance, CT scans from British people. This is all scanned, 100 people. This is the diameter of the chest from the breastbone to the back. And so, as you can see, the average in an adult is 25 centimeters, but there are much larger adults and much smaller adults. There are some differences between male and female. And surely this is also, as I understand, an issue in for instance, your region in Asia, where there is differences in physiognomy of people compared to other regions, and vice versa. So this is a true issue. This is another true issue. This is chest compliance. This is compression depth in millimeters. This is compression weight, and from these two, we're able to measure chest compression compliance in individual patients. And all these curves are individual patients, true patients. So there is a lot of difference in stiffness, say, of chests. And that also relates to the ability to compress the chest and achieve certain compression depth and achieve certain amounts of blood circulating in the body. So there are differences between humans. Now I want to conclude with giving you 4 ideas. The first idea on how to individualize CPR is to change your hand position on the chest. We say the center of the chest, we mean the lower half of the sternum, of the breastbone. But some people have tried to do differently in an individual patient and then measure end-tidal CO2. And as Professor Nolan explained, there is some relation between circulating blood and the level of end-tidal CO2. So by changing in an individual patient the position of the hands a little bit higher, a little bit to the left, a little bit to the right, these researchers were able to show that there are differences in end-tidal CO2 increase, so also increase in circulating blood. So I think this is an interesting venue. Compress deeper in some patients is also my recommendation. And this has been studied in infants following cardiac surgery, and this is an arterial line. And this part is compressing to half the diameter of the chest, and this is compressions to 1/3 of the diameter. Now, in children, the recommendation is to compress 1/3. This is standard, but this is not following the guideline, but going deeper. And as you can see, there is an increase in this patient of arterial blood pressure. Now, this is not proof that blood pressure is related to outcome, but it shows that we can change the effect of CPR by not following the guidelines. Did I say that? This is something else. This is playing with compression depth and vasopressors. Continuous infusion of vasopressors, not something we do. And it is in pigs. Okay, it's an animal study, a lot of indirectness, as Peter Morley said, but it shows that if you play with compression depth and you add some vasopressors, you might be able to increase coronary perfusion pressure, and that by itself is also related to outcome. This is my last suggestion. It has also been mentioned by Jerry Nolan. It is measuring brain oxygenation. Now, we're just at the start of this, and we know that there is some relation between the quality of CPR and brain oxygenation, and maybe, hopefully, we don't know, outcome. And I'm not sure if that's very visible, but this is the curve that one might be able to follow of the brain oxygenation. So with every compression, there is a wave. If you stop compressions, you interrupt, then the oxygenation immediately drops. And if you resume compressions, then the oxygenation increases again. Now, this is what you normally would see with good chest compressions. But with resumption of poor chest compressions, oxygenation stays low. So again, this might be an indicator of not just measuring compressions, but measuring the effect of compressions and an indication of better compressions. This is my last slide. It is the Stone Age, as depicted by Viktor Vaznetov over a century ago. And it shows some cavemen, and in those times, hard and fast was the way to go. I hope I have indicated that nowadays, hard and fast may be a good start, but there is a lot more to compression depth and rate, and I think we should adapt that. Thank you.